So AAC is also a great area for BCB and SLP to work together, especially for the younger population. And the SLP generally is the one that gives the diagnosis if someone have childhood apraxive speech, and that generally could be diagnosed past the age of 3. But I think SLP should be the professional to give that diagnosis and provide corresponding treatment in that area because they understand the language piece, the speech articulation knowledge, so that SLP can share with BCBA so that they could learn more and be able to carry that target selection at the home if they're working with them at the home or in the session, or working through upon behaviors to use that as a functional communication responses. Yeah. So that's very great area for collaboration, some of the parents, because stigma could prevent the family from seeking services. They perceive having a diagnosis of autism could be due to ancestral sinful doings. What the offspring is experiencing is they are redeeming of those sinful doings. And then they also have the superstition of the mother's carelessness during pregnancy. So there's quite a bit of blame on the mother's side. But we know that that's not really the case. But because of the stigma, culturally speaking, they might try to hide it under the rug and might try to delay those services too. And they might not, because of the English proficiency or access to the other families who are experiencing similar situation.
I'm Ben Reiman, and this is Behaviour Speak. Today I'm joined by Dr. Mei-Hua Li, who brings a really unique and valuable perspective to the conversation. Dr. Li is duly certified in behavior analysis and speech-language pathology, which gives her a powerful lens on communication, collaboration, and culturally responsive care. In this episode, we talk about what BCBAs and SLPs can learn from each other, especially when supporting autistic learners, AAC users, Chinese-speaking immigrant families, and adults with aphasia or apraxia. We also get into cultural humility, interpreter use, stigma, Confucian values, filial piety, and the beautiful community work happening through Chinatown Respite Care in Boston. This is one of those conversations that starts with interdisciplinary collaboration and then keeps opening doors into culture, language, family systems, community care, and what it really means to listen well as a clinician. Mei-Hua, welcome to Behaviour Speak.
Thank you so much for having me.
Mei-Hua, we can start a little bit about kind of your background. Tell me a little bit about kind of how you got into this work.
Yeah, so I am very excited to share about how I first entered the field of speech language pathology as an undergraduate. And then right after I graduated college, I landed a job working with non-speaking children with autism. And that sort of got me really interested in applied behavior analysis. And then I start pursuing my master's in ABA since then. And then I got really excited about the language part of it. And so I continue with my PhD at Simmons University and with a focus on verbal behavior and to look at how that could impact language learning, things like that too. And recently I also completed my master in speech language pathology now. So I'm looking to become, dually certified as a BCBA and an SLP. That's quite interesting. Yeah.
And what made you decide to go deeper and get the SLP certifications?
I think I work with a lot of individuals who uses a speech generating device to communicate. And I find that it's a beautiful place where BCBA and SLP work well together. And I find myself oftentimes maybe asking like, would this child learn better if they use this modality using an iPad, or would they learn better using sign or picture exchange? These questions could have been like further discussed with the speech language pathologist. I'm sure a lot of BCBA who work with this population potentially can benefit getting some consultation from SLP, and this could be a very nice area for the two to work together. And that also got me really interested in learning more about different type of devices, different type of speech generating devices could help with language learning. So Hence, I went back to speech pathology world and got my master in this area. And it's very interesting and so much we can do as a SLP too. They also work with adults who have aphasia, traumatic brain injury too. So it really covers a wide range of language in the life.
Really opens up opportunities for different types of folks to work with, eh?
Absolutely. That is really fun. The fun part about it is not just working with kids, but also work with older adults who might experience language difficulties. Yeah.
Absolutely. I've only talked to one duly certified BCBA SLP on the podcast. It was years ago. Landria Seals Green, early on. So I'm looking forward to learning a little bit more. I'm curious, what does it look like kind of in real life to integrate the two fields in your work with families?
I think a lot of it comes down to collaboration. I think it's really important to, depending on which setting you work with. I think as a BCBA, I work a lot in the home and with families, working alongside with the family, getting to know about like the needs of the child, their culture, that really blends in to getting like really combining the science and the practice together. I think that's really important. And for kids who might have language difficulties, if they have reading problems, for example, or they might have trouble articulating certain words, that's when the speech language side of view would be helpful to sort of chime in and help to select the correct speech sound targets. I think a lot of it, BCBA don't have trainings in developmental milestones, but they sometimes needing that knowledge to sort of figure out what would be the sound to teach and what sound one can teach to get additional free sounds for free. For example, SLP would say, oh, if they have similar place or manner, for example, the K sound or the G sound, as in cat or goat, teaching one sound in the similar place might potentially help you get the other sound for free. Like, I don't think ACBA knows that, but unless you consult an SLP, they might be able to point out things like that. To you. So I think having knowledge from both sides is also important as an SLP, where I practice as a clinical fellow now in the school. Understanding how to identify functions of behavior is helpful. Sometimes you might see a kid engaging in attention-seeking behavior or engaging in escape avoidance. You might try to figure out the function of the behaviors instead of putting the child in timeout or just like use negative reinforcement instead of just dealing with the behavior without knowing maintaining function. So I think the BCBA side complement really well with the SLP side of things, especially working with younger kids who might exhibit problem behaviors as a way to communicate.
We hear a lot about BCBA and SLP collaboration, and there's some folks out there doing some really good work on there. I know Dr. Lena Slim is one who does a lot of work in this area, is trying to sort of help the two sides, connect. And over the years, I've heard lots of different metaphors for trying to improve the relationship. Playing in the sandbox nicely was one for quite a few years in terms of workshop titles to kind of get folks getting along. It must be, it's obviously, that barrier is removed entirely for you, having both certifications, but you also see the real value of having both skills. What thoughts do you have sort of around collaboration between BCBAs and SLPs, because not a lot of people are going to go out and get both certifications?
Yeah, I think you'd name off quite a few very, I would say, famous figures who have been doing a lot of work in this area. I think it's definitely important to call for collaboration. And a lot of time we try to collaborate, but there are so many factors and barriers that prevent us from doing so. I would say like one of the things is if co-treatment, it's not covered by insurance, it definitely might not be the number one thing people want to do. And I think in addition to that, there are differences in terminology. BCBA might be calling the man, the tact, interverbal as basic elementary verbal operand. And then SLP might be saying, okay, the kids might be learning to label, to request, or use close phrase to communicate. All of us are communicating the same thing, but using different terminology. The divide could also contribute by the use of different terminology. And another thing, it's called encroachment, which is one is practiced sort of in an area without consulting another professional. So I think that sort of is how people perceive us as BCBA. So I think having some conversation about why we're working on communication and how we're going to target it could spark some very interesting conversation. And I think one more thing about BCBA is it's okay to be parsimonious, but sometimes some of us do question non-behavioral treatments. So some of us could potentially translate how some of these non-behavioral treatments into some of the behavioral terms and see how we incorporate into our treatment planning, potentially with the goals of helping the student to thrive. Yeah.
I'm curious about how the integration of the two might help support families whose first language is in English.
I think that's a very cool and important questions. I think a lot of the time we might be working with someone from a culture that's different than us. And in fact, the U.S. now is becoming more diverse. I don't have the exact statistic on my head, but by 2050, we will have like hit 50%. Of the diverse population. So with that said, we're just really going into someone's house or meeting clients that are very different from our background, how we were raised, how we view the world, that everybody has different worldview or different ways of treating when it comes to service delivery, the care that they seek for. I can speak a little bit about like Chinese and Chinese American community. I think if people that don't speak Chinese language, it might be a little bit difficult to sort of communicate. So if clinicians end up working with Chinese and Chinese American family who are seeking ABA services, they will have to work with a translator. And one of the courtesy of working with a translator is that you might need to find out what home language or heritage language that the family prefers. Most of the family that, especially in Boston, most of these family know like Mandarin or Cantonese, but they also speak another home dialect. For example, my family speak Toisanese. So some of the family might be more comfortable knowing working with a translator who knows some of their home language in addition to Mandarin or Cantonese. So as a clinician, I think being a little bit more mindful about who to select for our interpreter and how we work with these interpreter, they can potentially help us serve as cultural broker. So it's hard we can't learn every single culture, but what we can do is to sort of work alongside with the translator, get a little bit of background information about the family that we work with and get to know a little bit better about their family needs. So that ties in a little bit about the presentation that I have done at ABAI 2025, talking about how providing diversified care to Chinese family is important. And one thing I like to highlight is that for Chinese culture, it is deeply rooted in Confucius value. So I think understanding that is such a beautiful thing. So you can start having conversations with the families and to sort of understand why certain families they might feel like they're more resistant to services versus someone who's like, okay, you tell me what's important for my child, I'll do it. But certain things like if you don't understand how a Chinese culture or Confucius value work, you might find yourself at odds, making recommendations at taught with the family. One of the thing is in Chinese household, generally they might be living with a multi-generation family. So that you might be working not just with the parents, you might also find yourself working with grandparents as well. So in Chinese culture, filial piety is a big thing. So you would not be surprised when you work with a client asking you to write a goal to show respect to elders or show humility, like humbleness when you see a guest in the household. So there are certain things that sort of reveals itself as you build that rapport and have more deeper conversation with the families. So yeah.
You've introduced me to a couple of new terms, so I wonder if you can unpack those a bit. So, the first one is Confucius values. So tell me about that. What's that mean?
Yeah, so the Confucius value, so generally there is this philosopher in the Chinese culture that they see as Kongzi. So he's sort of like the guy that sort of like teach people to be how to live life in general, like the life values. So some of the life values include benevolence, courtesy, justice, filial piety, fidelity, humility, integrity. Some of these are the core values of how one should live life. And then that's sort of, I won't go into too much like the history behind this, but that's sort of how it drives the Chinese to live their life in general. So knowing that it's important because you'll be surprised that when you propose a treatment plan to a Chinese family, most likely they would nod and agree to it without like asking questions, without asking follow-up questions. You'd be surprised because they recognize teacher as a very respectful authority. So they generally takes in what the professional recommend and do it. So versus another culture, they might operate in a completely different way. I don't know. But it just how interesting knowing about that is important. There's an article called Master et al. 2019. It's sort of called, it labels the 5 R's of cultural humility. Why is it important? Because sometimes we might walk into a household with our own biases. And to set that aside, it's important because we need to sort of what we impose on the family. It's correct because the family might already have a value that they follows and things like that. So the Master et al. 2019 paper also focused on the 5 R's, which are the reflection and respect, regard, relevance, and resiliencies. So I think that's a quite interesting paper to sort of how to set aside your own biases before you step into someone's house or start working with a client when you pick up a new client. And when you do these assessment, you can also use the FAI, the functional assessment interview, and to further ask these questions, open-ended question. Moreno et al. 2014, one of the authors translated the Chinese equivalents to this interview so that they can ask some more deeper conversation and get a better understanding of the families too. So it's important to use bilingual materials too, because sometimes you might say, oh, these questions might not be as culturally sensitive to the family that we're serving. So having these materials are important. If there are translated versions, of course, yeah.
I love that. We'll link those papers in the show notes. One of the Confucius values you mentioned, and you referenced it again, was filial piety. What's that? Am I saying that right?
Yeah, absolutely. That is so interesting. Filial piety, it's like showing respect to elderlies. So I would find myself, especially when I go to family gatherings, I would be seated with a group of elderlies or people my age or my parents. And then generally my parents would sort of taught me to be a good child or family member to let the elder eat first. Filial piety, it's been shown by when you let the elder have the food first or let the food being served first. And the virtue of it is that that's how you show respect to others. And also when you like see an elder coming into your house, you will like to greet them and you wish them well and things like that too. So that sort of is the essence of filial piety of it. So I think it sort of also ties into courtesy too and humility, a little bit of that. I think having that understanding of it, it's so interesting, especially in a multilingual, multi-generational family too. So yeah.
Yeah, and courtesy and humility make a lot of sense to me. Can you also maybe give me a couple of examples of how benevolence plays into this?
Yeah. So I think sometimes a lot of benevolence. So I think benevolence plays a role in this because we always want to do good to the society. So I think that as BCBA, so tying this back to BCBA, I think we always want to do good to others. So having that intention is good, but you want to do it in a way that it's culturally, want to tie it back to culturally sensitive too. You might be doing something like, for example, a child might needing some help to feed themselves. So instead of assuming that a family would want the child to use a fork to eat, working with a Chinese family, a question that one could ask is, do you want the child to use chopstick? How would you like the child to eat their food? So I think that's important to ask these questions because we want to do good, but we want to meet the child where they are and do it in a way that not just show respect to the family, but also include their inputs in the treatment planning as well, too.
Wow. And just tracking back a bit too, you were talking about something I had never thought about before until today when you mentioned it. We always think about the importance of having a translator but I would not have ever thought about dialects until you mentioned it. And so is this something that's common, something we want to think about across languages, or are there a lot of languages that have like a lot of dialects that we need to be thinking about when we're looking at translators? It seems it's a whole sort of different world to unpack when you're sort of out there seeking translators.
I think that's definitely an area that BCBA can have more practice in too. I think working with an interpreter is very helpful if you can find an interpreter who can speak the language of your clients, and if they speak the dialect, it's even better because I might have the statistics here for Asian BCBA and BCBAD, according to the Behavior Analysis Certification Board and the certificate data, they're only 7.91% people for BCBADs. And then for RBTs, there are 5.25% for Asian descent. So you will notice that, wow, that's such a small population. It's hard to find an RBT who speaks the Chinese language already. So we must go through the interpreter sometimes. But because, finding an interpreter could be hard, but what we can do is to lean back on Cantonese or Mandarin, because some of these families do speak a more official language of China, which is, if that's really the last resort that we have to go back. But if someone do offer the dialect, we could potentially use that for our interview as well too. And I think through the process, we can also learn better to work with interpreter and learn more about the family's culture backgrounds as well. Yeah.
I've had a couple conversations about stigma, and one conversation about a bit about stigma in the Chinese community. Can you tell me a little bit about sort of how diagnosis can be sort of stigmatic in Chinese and immigrant communities, and what that looks like and how it shows up when families are first seeking services?
Yeah, I think sometimes it's very important to recognize stigma in addition to limited English proficiency for some of the parents, because stigma could prevent the family from seeking services. I think some of the stigma that I've read in the literature or no friends that are dealing with are
they perceive having a diagnosis of autism could be due to ancestral sinful doings. And then what the offspring is experiencing is they are redeeming of those sinful doings. And then they also have the superstition of the mother's carelessness during pregnancy. So there's quite a bit of blame on the mother's side. But we know that that's not really the case. But because of the stigma, culturally speaking, they might try to hide it under the rug and might try to delay those service too. And they might not, because of the English proficiency or access to the other families who are experiencing similar situation, they might lack the awareness of what are the services out there. They might not even know about ABA services that they can see through an IEP if they are in a school, or like they can get home services if their insurance approves that. So that these stigmas could potentially cost the parents sort of turn them away from getting services. And when they get to a point where the student do go to school, they receive service through IEP, then that they might sort of already hit other roadblocks where they are delayed the service long enough. The kids didn't get the service that they could have done when they were much younger. And also another thing is there are long wait lists, as we know, especially in the US. I feel like in Boston, the wait list generally pretty long to get on ABA services, especially ones perceiving services through the home agencies. Yeah.
And I wonder about what even access to diagnosis kind of looks like, especially when maybe English isn't available. Are there a lot of sort of Mandarin Cantonese speaking diagnosticians that can do these assessments? How do families sort of deal with some of those barriers?
Yeah, I think in Boston, I think there are a small network of doctors that might speak both Chinese and English. When I say Chinese, is refer to Mandarin and Cantonese. And then for those who don't speak the Chinese dialect, they also access interpreter services. And through those, they can get the diagnosis of autism. And then from there, the pediatrician or neuropsych might be making the referral for additional services like ABA services, speech and OT if they qualify for, if the profile calls for those services. And these families will then follow the doctor's recommendation, sort of get the autism diagnosis and to share that either with the school or with their other service provider, just so they can start accessing some of these services. And I think it usually when parents first get the diagnosis, they might feel overwhelmed and also not really understanding how the U.S. Healthcare system works. So I think things might be a little different in Canada, which I can't speak to, but in the U.S. Healthcare system, one will need to sort of go through insurance to get these services, and then they will get authorization to get an initial assessment if they qualify for ABA services, and then they will get connected. They will get connected to an agency, and then they would get connected to the therapist, to the BCBA, and then also hire an RBT to be able to conduct some of these treatments at home with the goals written up by the BCBA, and then also with parents training. And then that sort of goes back to, we might not have a lot of bilingual BCBA providers here servicing Asian or Asian American families who needed the service. Then they might need to either look into more background information about how to work with this population, especially with Chinese descent, Chinese or Chinese American descent, or they work with RBTs who might know the language, and also interpreters as well. I feel like as a clinician myself, I learned so much from the families that I work with. I have worked with Indian families before, and I find myself don't know a lot, but I'm constantly learning, and I love the term cultural humility instead of cultural competency. We're not just seeking to become competent in servicing individuals from diverse background, but we are a lifelong learner, that we are continue to learn and gain skills and learn to better serve our clients. And there's no one size fit all treatment. So
we can always learn more and do better in this area.
Yeah, no one truly becomes competent in any area because that sort of implies learning is finished.
Yeah, absolutely. That's right. And our ethics codes also call for practice cultural humility, code 1.07, 2, and 4.07, which is to incorporate and address diversity into. So if you want to really break these down and try to incorporate that into practice, it does require ongoing learning. And I think as BCBA too, that would serve as a good model for your RBT to do the same too, because maybe the RBT spend more time in the household than you do. So I think it's good supervision model to sort of model that diversity and ongoing learning as well.
Wondering about how clinicians can begin to identify some of these cultural stigmas that may affect services.
I think that is very important to have that identified, especially when you do initial assessment. I think parents are generally more open when you have a good rapport and you build trust with them. They tend to open up. I think that showing that you are there for their families and you showing that you spend the time to learn and educate ourselves about the differences and really spending the time to find the common ground could potentially help open up some of the avenues to identify the stigmas. And sometimes it is hard if families do not open up because of various reasons. They might find it shameful to share about the family's trouble. They might just not open up and show resistance. And I think that going back to pairing ourselves, we also talk about pre-session pairing with kids, but we can also do pre-session pairing with the parents, which is to build that relationship so that the families can share more about what is bothering them and how they would like to work with you to identify a workable solution for both parties. The BCBA do the technical stuff, and then the families can follow through and help with the generalization piece, because BCBA can't be there forever, right? But we can sort of build that relationship, teach and coach them the skills so that they can also generalize some of our programs when we're not there.
What are some common misinterpretations clinicians make?
I think sometimes I find it very interesting to identify biases. That's important before we sort of start working with a client, because I'm sure there are some tools out on the internet where we can learn more about. And why do I keep saying identifying biases is important? Because we might think a certain way. We might be very good at doing certain things because we can change behaviors, but not all behaviors want to be changed. So to do that, so we need to sort of understand and paint a better picture once we get to know the family better. So I think I usually try to err on the side of caution when I meet a family. I try to ask more open-ended questions. And if it's because I work in the home, I generally the first impression matters. So I just generally ask them questions like simple things like, do you want me to take my shoes off when I'm in your house? I think simple question like that would be helpful, because the family would see, oh, they do like pay attention to things around my home, and that sort of show that you care about the family, and then you can sort of ease yourself in. And I do remember a recent interview that I have with a family. They offer me tea, and generally I might or might not take their drinks, but because they offer a drink, culturally speaking, it's okay to as a way to accept their offer by taking their drink of water. So I say, yeah, I would love to have the drink. And then they offer me a little bit of a snack. Generally, I'm not hungry, but I understood that accepting these snacks is their ways of showing hospitality. So I rather sort of accept that instead of saying, no, I don't need it. I'm not hungry. I think showing things like that would be helpful. That could potentially prevent a lot of misconception, like, oh, I'm here for work. I'm not here to eat. So I think doing a little gesture like that would come a long way with family.
What are some practical, concrete strategies you recommend for delivering culturally responsive ABA services?
Yeah, I think I would tie it back to because we now imagine you're in a place where you learn so much about it already and talk after you talk with the family. And I think the first step is to have parent training to go through some of the goals that you have with families and ask if they have any questions and really encourage questions because as we know, Asian American families might or might not ask the question. Or maybe you can list some examples of what are the common questions that other families would ask that sort of prompt the questions from the families. And then you can keep like answering the question and providing more information for the family. The goal is not to like overwhelm them, but give them open space to ask the question that they need and to really understand why you are writing certain goals and really get that buy-in. I think that's really important. I think also usually Chinese families are interested once they start getting ABA services, they want to know what other services that they can get because taught them that, oh, my child can access the other services. They might be interested in do the other providers speak Chinese or Cantonese Mandarin. So not just familiarizing yourself with the culture background is important, but if you're like local, you know, any organization that serves Asian Americans, like be it after school program, social workers, or additional private speech would be helpful who are also bilingual speakers. Most likely these families are seeking multiple services. And if you can connect that parent or the families to outside providers would be very helpful. And also these parents need community supports. And if you can connect them to, for example, a Chinese speaking parent support group would definitely help them to share additional resources. There's so much we can do. It's just we need to get on their side first so that they can be more open up and more willing to accept additional support or resources that we can offer.
I love your point about questions. I think often when families don't have any questions, we assume they understand what's going on and they understand what's happening here and they understand the plan, they understand, you know, what services we're going to be providing. And you make a great point that just because there's no questions doesn't mean there aren't questions. And we need to help families ask the right questions and prompt them so that they can get all the information they're looking for. I really like that point.
Yeah. I think it's no question. It's okay sometimes, but more question the merrier, right? Yeah, I definitely love the families when they ask a lot of great questions. But it also depends on which stage they are. For example, if they've just got the diagnosis, they might have more questions than the ones who had already been receiving services throughout their school or other places. And then you might be the bilingual SLP or BCBA that fully certified or just BCBA they work with. So they got really excited and they start sharing what had worked and what had not. So you could be the person to really help bridge the gap here. So yeah.
You talk about the importance of community supports and parent supports. I'd love to talk about sort of one of the original reasons why I reached out to you was the work you're doing with a group called Chinatown Respite. Tell me all about Chinatown Respite. Who are they? What do they do? What do you do there?
Chinatown Respite Care is a very interesting find in my pursuit of applied behavior analysis. In fact, I learned about this nonprofit organization while I was doing ABA, and I was looking to apply some of my skills that I learned in grad school. And I came across this nonprofit organization which serves neurodivergent Chinese-speaking immigrants. And generally speaking, they want to provide a space for the parents to just relax once a month so that they can spend time with the other family members and also friends from the community that speak Cantonese or Mandarin to just talk about anything they like. They might be sharing resources. They might be talking about how to navigate IEP. What does it mean to have an IEP? And 504. A lot of these information sharing is very valuable. And I also remember hearing a parent celebrating their success, how extra services help them. Special education services help their kids thrive. And it's just very interesting. We not just service parent group, but also have programs for the kids while the parents are taking a break. So on the kids side, we also have programs for the younger kids. We generally service ages 3 to 18 with our oldest who are now in college now pursuing computer science. So that's really interesting. So they sort of graduated from our program, but that's really an important community space where everybody can take a break once a month from taking care of children with special needs. As we know, it's not easy to raise kids in general, but especially kids with special needs, parents do experience higher stress because be it the language barriers, access of services, not knowing how to navigate the U.S. healthcare system could be adding on a lot of stress to their day-to-day work. And they might be dealing with maladaptive behaviors or might be figuring out how to get a speech-generating device for the child. So a lot of questions for the parents could be answered, or maybe find someone who could answer through these support groups. So this is a very tight-knit community. And one nice thing with this group is that once you connect to one person, they have connection to many other families. And then by those spread word of mouth, and then they get more families into sort of this group that we have together. We do meet once a month in the Boston church setting where they just bring the kids and drop them off. And sometimes we also have workshops for the families too. And also for the volunteers who work with the kids one-on-one to let them learn more about not how to work with kids with special needs. I also run some workshops for them so that they can learn how to use behavioral strategies to work with when there are maladaptive behaviors, how to pair pre-session pairing with the kids, use manding verbal behavior approach, as well as we have other topics such as nutrition, music therapy. We also have recently developed a new vocational training program for the teenagers who are looking to get a job post high school. Yeah, so I think that's really interesting, targeting across age group, but with the focus of Chinese immigrant family. Yeah.
Really cool. And is this service free to access for families?
Yeah, it's free for all. And then we also provide dinner. I think that's one of the big selling points too. I think in Chinese culture, one's find beautiful conversation happens during food time. So I think the food really bond us really well. And being able to have the family come in to have rest time with the other families, but also a time to eat and to celebrate. Wow, we just have time and see so many people that we haven't seen for a month, or because these students might or might not go to the same school, but it's good to see their friends and good to see other families. And then I think the food bonding piece is such a plus for a lot of the kids too, because they all enjoy meals together, and it's such a nice bonding activity to have. And we also have other programs for the kids as well.
And so how many families are you serving through the program?
Currently, we're serving about 30 families, and previously, this organization was started in 2016. And before COVID, things were a little different. They meet in a Boston Chinatown location, and then the families sort of like have their separate rooms where they sit and have their bonding time, and then the kids have their individual classrooms. They could be working on crafts and learning about the Bible or things like that. And also they do movement breaks, songs, and do different activities together. And then gradually COVID hit. And we weren't able to reach a lot of the families. So we have to sort of host online workshops. So I think that's sort of some way to reconnect with the family. I think COVID sort of reset everything. And then by like 2019, things start getting back to the new normal. And then the families were able to return. And then
at this capacity, we are serving 30 families. That's about 60 people to feed for dinner. So that's quite a big production every month. But I think that's very meaningful because the families who have came to our Chinatown Respite Care before, some of the kids have already grown up. So the older parents or the family group liaison, they are more experienced so that they can coach the younger parents to go through and understand some of the things that we have mentioned before, how to navigate IEPs, how to get a device for a child, because sometimes getting a device, a speech generating device, could take months. But because some of these parents have experienced it, they know who the right person to ask and how to follow up with the person at the school to get the necessary tools to help their kids to communicate. Because especially for non-speaking child, they don't have a device. It's just hard for them to communicate. And they could learn sign language and things, but if, for example, if the professional like SLP decided that the speech generating device is the thing, then someone needs to sort of figure out the process and get the device right in. And I think with family, to navigate that process is hard. And given that, I think the healthcare system is different in China versus here. So it's sort of like a cultural shock to them. But once they get used to it and understand how it works, they find it helpful to be part of the group.
Really cool. I really see that, giving back to the community is one of your core values. How does that value guide the decisions you make as a clinician, educator, and advocate?
I think that's a really cool way of thinking about this. I think I personally grew up in Boston, Chinatown, and it has a special place in my heart, and it have helped my family so much when I immigrated to the US when I was the age of 12. 11, sort of. And then I feel the need of giving back to the community, and now being able to use the knowledge that I have gained through my graduate training. I think it's so meaningful to be able to help individuals who are going through the process but unsure of how to proceed. And I also am very excited to sort of motivate others to do the same. And in Chinatown Respite Care, not just ABA providers are serving as volunteers. There are so many others, professionals who are interested serving people with autism. They could be occupational therapists, physical therapists, and also Harvard Law professor who just interested in serving this population because they speak the language. And I feel like because the language piece that really connect a lot of the professional that's kind of chimed in and share the expertise of how to serve this population better. And I think the kids definitely benefit so much from these close relationships that they have dealt with these professionals as well, because they have someone to look up to, and they can serve as role models, which I think ties a little bit back to Chinese culture, respect the elders and also follow a respectable figure so that they can pursue their dreams. So I think that's one of the ways how it not just shaped me as a clinician, but also teach me how to be humble. Going back to the topic of being humble, I think not just the volunteers, to the kids, the families, everyone at the organization taught me so much to be a better leader, to be someone who voice was what are the needs from our students. And I think one of the things that I'm really excited about, which I mentioned earlier a little bit, is the vocational training, because there hasn't been any program that focus on just training Chinese immigrants that are Chinese speaking youth who are also autistic to gain the necessary skills to get a job in the future. So some of the topics that we currently worked on are executive functioning skills, problem solving skills, and organization skills. And with that, we did a little bit of a project, and we designed some arts and crafts and sold it at a booth at the Hong Kong Festival.
which was quite interesting because it happened during the month of May, which is Asian American Pacific Islander Heritage Month. So we sort of tied it in, share about the culture. Some of our teens were the one that explain how and why they make the crafts that they did. And then we also have an artist who paint beautiful paintings and sort of help us fundraise for the organization. And it's also a good way to take pride in one's culture and being able to share like, oh, I know Cantonese, I know Mandarin, I can switch between Cantonese and English fluently between the two languages. And then it's just people find that such a beautiful thing that they can embrace the culture and also their language identity as well. So I think it's such a applicable way of not just teaching them the hard skills, but they're able to sort of integrate that with the soft skill when they interact with other people, and also inadvertently working on the social pragmatic skills that kids with autism sometimes might need some support with. I think the kids' feedback was positive. They said they want to do it again. So hopefully we can be able to provide more opportunities like that and for some of these kids. Yeah.
Shifting a bit, I'm curious about, because you were talked about these values and the curious how that value in particular sort of plays into the other work you're doing work with more elderly populations, folks that have struggled with stroke, folks that are starting to, maybe feel some of the effects of sort of dementia and things like that. How is that value kind of contributed to that work for you?
Yeah, you have brought up a really great point. I think studying in speech language pathology opens up the other area where I work with adults with who have experienced a stroke, and then they might experience something called anomia, which is word finding issues. As we know, our population are aging, so we might be encountering individuals who might have experienced a stroke or traumatic brain injury that they could potentially need support in language or word finding or just general support in that area. So I think working with adults it's interesting in that area because for my master thesis for speech and language, I did a study on how to use something from the speech world called the semantic feature analysis, coupled with behavior treatment, prompt fading to help someone find words. So essentially what I will define what semantic feature analysis is. That is sort of like you work with the existing network that the person still has after having a stroke. With that network, some of the words might still have some weak or lost connection. So what we can do is to use, through talking, close phrase, we can sort of reestablish those connection between words. For example, if one cannot describe car, you can ask them to describe what does it look like. Oh, a car, that thing could have wheels, windows, and then when you describe it, it sort of make the connection between words and semantics stronger. And semantic feature analysis sort of tap into the different questions that you can ask. What does it do? What does it look like? And you can also ask, what does it remind you of? So, and a lot of these is to prompt individuals to find other words to describe it. Partly it could help the person find the word that they are looking for, which in this case, car, or they could help the listener to figure out, oh, you mean car, that could benefit the listener as well. So with that, in the speech world, it has proven to be effective for mild to moderate patients with aphasia, but they haven't tested with more of the severe and individual aphasia. So what we did is to sort of take that protocol, condense it more to just really focus on 3 areas. What does it look like? What do we use it for? And what does it remind you of? And really train them repeatedly with these 3 points, and then couple that with prompt fading, because as BCBA, we know having a systematic way of teaching and systematic way to prompt fade and fade out the prompt, it's important. to help our clients so that they don't become prompt dependent. So sort of using that, we were able to train 6 participants with mixed different levels of aphasia to gain some of the words, at least the word that they were trained during session. And we show 2 out of 6 participants have some generalization for the words that we have not trained. So that it's benefit to them. They can also walk away with the visuals helping them. So some of the visuals might started off providing the color and also the icons that reminds them for looks like they might be, it's hard to see if you're on the podcast right now, but pointing at the corner of the eye to indicate what does it look like. And what do we use it for by raised of a hand so they know, oh, we use it as for the function. And then the other one, and what does it remind you of by pointing to tapping your head. So that's sort of these cues can help these participants to remember what else to say if the word becomes difficult for them. So having these gesture also support individuals who have difficulty speaking with apraxic speech. So what that is, the order planning is hard. So for example, if they say the word cookie, the next time you ask them to say it, they might end up saying "okie." So saying the same word could be hard, but having them be able to use shorter phrases and use gesture to describe would be helpful for them to talk around the word that they are looking for. So this work, it's really to support individuals who are experiencing difficulty with word finding, and it's helpful for individuals who might struggle finding that one word that they're looking for. And through that training, hopefully strengthen that semantic network that they had previously before the stroke. So that's sort of a little bit of a strength-based approach, which is fabulous, because once the participant may gain, they feel more confident about their speech, because it's just so difficult for them to kind of cope with the language piece when stroke sort of interfere, sort of changed their whole network.
And so I don't know a lot about aphasia, and so with aphasia, it's the idea, that they're not able to, kind of come up with words for things or remember sort of how to express these thoughts. Is aphasia sort of a retention of past knowledge issue, but they can still retain new knowledge, or is it a little of both?
I think aphasia generally is more of a language disruption phenomenon that one might experience. It does not impact the memory or attention. And I say that grossly. Depending on the region of where the stroke happens in the brain, if it does impact the language region of the brain, it can make speaking difficult. I probably won't go into too much detail of the categorization of more fluent aphasia or non-fluent aphasia, but the general picture is aphasia do only impact the language part. They could still, the individual can still understand you fine, and they can still remember things, maybe with some reduced cognitive abilities or attention, but most of their other brain function is still intact. I say that because only if it's impacting the language region of the brains. As we know, the brains sort of communicate contralaterally, so that goes into a little bit more of the anatomical physiological things of the brain, the anatomy of the brain. So I think that understanding that it's important so that we don't try to talk like the person do not understand us. We can adjust our speed, because sometimes when we speak slowly, they can understand us better, because retaining all the information could be difficult. And sometimes we call this, speech language pathologists call this having aphasia friendly handout. It's helpful. When they say aphasia friendly, it means when you have written sentences, keep them short.
keep them concise, and allow spacing between the words so that they don't have to read so much text on a printed paper. And also adjusting our pace or reminding them to adjust the pace is also important. So a lot of the time if we go too fast, I would remember a person with aphasia would be like, slow down, like not retaining what you said. And then I would sort of readjust my pace. And then I would repeat keywords. Sometimes typing out keywords is helpful. We might have been saying, oh, can you repeat the word? Instead of saying, can you repeat the word, type the keyword either, because we've done our study online, typing the keyword word would be helpful. And telling them what to do or repeat after me is helpful as well.
And then we're kind of tangenting from the main theme of the topic, but I'm just more curious now. So how does apraxia differ from aphasia?
Yeah, I think these are very interesting distinction that we need to make between apraxia and aphasia. This is really going into the speech side of things. Apraxia generally refers to the motor planning. Apraxia just means like motor plan. Apraxia just means the motor plan is disrupted. So what that means is somebody might be thinking of a word. They might be thinking of cookie, or they end up saying bread. So that is the motor planning piece. It's disrupted. So their mind is thinking of a word. What comes out their mouth is a different word. So that's a disconnect. That could also due to apraxia. Or maybe sometimes they are thinking of the word like I gave earlier, like cookie. It might came out as uki or came out as buki because they just don't have that execution of the sound like they used to. So apraxia is different than aphasia. Aphasia is the word finding. They might find the wrong word that they are thinking, or they might have tapped into a word that sort of related, but not the exact word that they're thinking. So I would say aphasia is more like word finding. Apraxia is more of a motor plan execution difficulty.
And either way, these are things that are kind of out of their control. Like they could be thinking about a word and know the word and maybe even know the full sentence they want to say. But as soon as they try to open their mouth or whatever to do it, it just doesn't come out.
Yeah, that's exactly the case. And when both combine, it makes it even harder to communicate. And that's when the frustration comes in. And I think that potentially that could impact someone's quality of life and also decrease their chances of speaking, because speaking is hard. And when others do not understand them, it just causes more frustration to communication. So I think definitely BCBA can work alongside with SLP in this area. Going back to the collaboration piece, I think SLP knows so much about the brain that they can contribute, but BCBA also can focus on the data collection. How can one systematically teach a strategy and sort of track the progress over time? And we're really working on that generalization piece is helpful, because we could teach a therapist to and a patient and their families to run a procedure, but if they're not able to do the same thing to order coffee in the community, that sort of lose the importance of training, because a lot of it, these patients might just needing to be able to read their grandchildren or be able to order their own coffee in Dunkin' Donuts. We have Dunkin' Donuts here in the US. So I think that would be interesting for them to practice their skills in the community, just outside of their home. So.
Sure. Because I'm also thinking about apraxia and maybe aphasia to a lesser extent in the context of the non-speaking autistic population, and not folks that have had strokes or other sort of traumatic brain injury, but just folks that don't speak. And is it possible that in some of these folks, that's kind of what's happening? And this, because it leads me to think about sort of this sort of it's a sort of idea of the presumption of competence in a lot of these folks, and that we often sort of label them as less intelligent or this intellectual disability or things like that. And I realize this can lead down, a slippery slope maybe into some interventions that have, caused a lot of controversy and whatnot. And so I'm not looking to kind of go down that path, but it does make me wonder about sort of the non-speaking individuals that we're serving, and their capabilities, and how something like apraxia might be a limitation that we're not considering in our interventions.
I think that's a super cool connection that you just made here, Ben. I think apraxic speech, yes, definitely, that could impact individuals with motor planning execution. I think it might seem a little different when it comes down to our little ones. With kids, they might not have a language that was intact before stroke. So for clinicians who think about working with non-speaking individuals, they might need to think about the language developmental piece of things, and also how to teach in a way that the kids can access their needs, the wants and needs, because that should be the number one priority. And to do that, they could I keep saying that SLP because SLP sort of know these things so well. So to be able to find a modality that works best for them so that they can communicate. And BCBA can often comes in and use functional communication training to kind of teach that communication piece. And then SLP could be the one that say, okay, let me just add in some more additional descriptors like 2-word utterances instead of just cookie. The SLP might say, let's just teach a big cookie instead of just cookie. Or maybe I like to get a red car, which one? And then be able to answer questions relating to WH question, recall past events. Lately, there's been more research coming out with speech generating devices, just sort of taking what we have already known from teaching vocal learners and to see how we can adjust and teach those who are non-speaking. So I think the apraxia piece, yes, is there. And also it dependent on whether the child is stimulable for gaining sounds. And there's one thing that the SLP might often say is that using the device does not prevent someone from learning to speak. So that might be a misconception sometimes parents have, like, what if the child is already on a speech generating device? Do they just don't learn to speak vocally? That is not the case because speech generated device could be served as an augmentative and alternative communication and a supportive role to language learning, be it vocal speech or literacy. And as they get older, they will start learning to read, to decode words, to spell words. So language just sort of built from all these things coming together, not just one small aspect. So AAC is also a great area for BCB and SLP to work together, especially for the younger population. And the SLP generally is the one that gives the diagnosis if someone have childhood apraxic speech, and that generally could be diagnosed past the age of 3. But I think SLP should be the professional to give that diagnosis and to provide corresponding treatment in that area, because they understand the language piece, the speech articulation knowledge, so that SLP can share with BCBA so that they could learn more and be able to carry that target selection at the home if they're working with them at the home or in the session, or working through upon behaviors to use that as a functional communication responses. Yeah. So that's very great area for collaboration. And for the older folks on the older population, I think understanding that apraxia speech is also interesting because the adults might not need a lot of
toys to entertain them. So preference assessment is still useful for working with adults who are experiencing a stroke. But you will find yourself needing to play with them because they already have interest. Having conversation could be reinforcing enough. A verbal praise would be reinforcing enough versus working with kids we might have to constantly check for their motivation and constantly identifying reinforcers that sort of help them gain that skill. So it just sort of need to know the shift between the population that we work with as well as the age group is important.
Fascinating. I really need to talk to more SLP, BCBAs. These conversations are always so interesting. Before we kind of close, is there anything you'd like to emphasize, clarify, or protect about this work? And where can people learn more or engage more responsibly in this area?
Yeah, I think this is such an interesting topic. I'm really happy to share more about anything, but I would encourage if any BCBA are bilingual speakers, establish yourself as such, because maybe there might be families who are looking for service providers like yourself to seek services. So do that. I think the BACBs might not have a tab where you can enter that information, but on your personal website or other social media platform that you use to use for your business, I think that could be helpful to establish that. I think that's huge. And also keep a running list of collaborators that you can work with or know who speak another language, sort of have that running list. I keep adding to my list. So if families need referrals, I'll have this list ready. So usually the parents would be content. And the more they know, the happier they are. So yeah, thank you so much.
I love that. Thanks, Mei-Hua, for coming on the podcast. This is really cool.
Yeah, absolutely. My pleasure. Thank you, Ben.
Before we wrap up, if you enjoyed this conversation, I'd encourage you to check out a few related episodes from the Behaviour Speak archives. First, take a listen to episode 270 with Diana Yip, Beyond Compliance, Supporting Children Across Cultures with ABA and PBS. In that episode, we explored culturally responsive practice, family values, and how practitioners can move beyond a one-size-fits-all approach when supporting children and families. You might also enjoy my conversation with Chloe Wang, Building Culturally Responsive Family-Centered PBS for Immigrant Families. There are so many natural connections between that discussion and today's conversation, particularly around cultural humility, collaboration with families, and adapting services to better fit the lived experiences of Chinese immigrant communities. And be sure to revisit episode 212 with Hazel Lim, Empowering the Chinese Autism Community. That conversation highlights community leadership, advocacy, and the importance of creating supports that are culturally and linguistically meaningful for Chinese families. Together, these episodes paint a broader picture of what culturally responsive, family-centered, and culturally informed support can look like across behavior analysis, education, and related helping professions. As always, you can find those episodes and hundreds more at behaviorspeak.com. Thanks for listening, and until next time, keep fostering meaningful behavior change through compassionate, evidence-based practice. Take care.